Today's webinar will focus on how to use image guidance, including ultrasound, CT, and cone beam CT in various clinical cases. Our speakers will share real-life examples from their daily practice, so we hope you will find it both practical and inspiring.
This table from CBCT guidelines on percutaneous needle biopsy compares of imaging modalities. Ultrasound has certain advantages such as portability, availability, real-time imaging, and low cost. So the question is, which probe should I use? For superficial lesions, linear high-frequency transducer with a frequency of 7.5 to 15 MHz can be used. For abdominal or thoracic interventions, curved or phased array transducer with a frequency of 3.5 to 6 MHz can be used.
Here is what that looks like in the IR suite. This is a typical setup. The C arm carries the X-ray tube and flat panel detector that rotate around the patient. The L arm holds the system, giving us flexibility in angulation. And on the monitor, we can see both live fluoroscopy, which allows real lifetime control in 2 dimensions, and the reconstructed CBCT images. As you can imagine, the open trajectory setup also provides great accessibility to the patient and allows to move the table and center the field of view.
And now we will see some cases. Our first case for today is a 66 years old female patient who presented with obstructive jaundice and significant weight loss. She underwent an ERCP with placement of a plastic biliary stent for decompression, and her imaging reveals a solid lesion in the head of the pancreas. You can also see the plastic stent clearly on the CT scan, and the patient was referred to our department for a CT-guided core biopsy in order to obtain a tissue diagnosis. So after reviewing the pre-interventional imaging, the lesion was best seen in the supine position. So there comes sterile preparation of the abdominal and administrations of 10 milliliters lidocaine subcutaneously. And as you can see on this picture, we always leave this needle of the anesthesia as a radiopac marker to confirm our planned trajectory. So step by step, we advance the needle towards the lesion, performing Schoner control scans to verify each advancement of our needle. And once the needle tip reaches out the lesion, we confirm this position with a quick scan. And that's the moment when we are sure we are ready to take tissue samples.